Hello, this is Matt Link, president of NuVasive. What we're experiencing today is truly unprecedented. And as a company, we want to make sure we're learning from one another, from industry leaders, and those that have valuable perspectives during this crisis. Joining me is Dr. Mark Freeborn, an orthopedic surgeon from the greater Seattle area at EvergreenHealth, and Dan Wolterman, retired president and CEO of Memorial Hermann Healthcare System. In this two-part discussion, we will share learnings from our surgeon partners, as well as health system and hospital administrators on the impact of COVID-19 on our healthcare system, and specifically in spine, as well as what does recovery look like, both a near and long-term outlook.
Thanks, Matt. So my name is Mark Freeborn. I'm an orthopedic spine surgeon by training, and I practice at EvergreenHealth in Kirkland, Washington. In addition to being an orthopedic spine surgeon, I'm the chief surgeon for the EvergreenHealth system.
Great. Thanks, Dr. Freeborn. And Dan, can you share with your background as well?
Sure. My name is Dan Wolterman. I live and reside in Houston, Texas. I was the president and CEO of Memorial Hermann Healthcare System, a large regional IDN in the greater Houston area for 17 years. I retired from that position 3 years ago. My background is 40 years of hospital and healthcare executive leadership positions, a lot of that on national health systems. The last 5-6 years, extensive experience on a med device and medical technology company board of directors. That includes NuVasive, Vizient, Intuitive Health, and others.
Great. Thank you, Dan. So look, appreciate you both again, giving us your time and more importantly, sharing your experiences here as we're, living through which is, a completely unprecedented time. And I wanted to start with the impact of COVID-19 on the broad healthcare market, and obviously an area of specific interest for us and those listening to this is the spine market, and better understand what can we learn, or what are the learnings from your experience and what you're living through right now? And Mark, I know this is particularly relevant for you, your health system and colleagues up in the Seattle market. So, with that, Mark, the Seattle community experienced COVID-19 before anyone else in the U.S. What have been those critical learnings? And perhaps as you think about that and share what's worked best practices, procedures, and also I think very important, what are the things that you saw didn't work that can help inform other markets that are ramping up for this challenge?
Sure, Matt. Obviously, that's a pretty significant question. Whenever somebody or one of my friends or family calls and asks me, how are you doing? I almost feel embarrassed because as a surgeon, your job is mainly to stay out of the way. As far as what we've learned, and we are now, as you've alluded to, through the majority of this, at least we hope that we are. So we're in a period where we can reflect back on what we've experienced and also look forward. Some of the most significant things that we've really spent the most amount of time looking back on are, wow, how did we get so lucky in making it through this and avoiding the, I call it, apocalyptic scenario that some of our other brethren cities are going through. And so when we look back at what Seattle experienced, and just to give a little bit of background, we had a nursing facility or skilled nursing home 5 miles from EvergreenHealth that we typically see a lot of patients from. That skilled nursing facility had a large number of patients turn positive almost overnight, and all of those patients were sent to EvergreenHealth because EvergreenHealth was the hospital of choice for that nursing facility. So we were immediately inundated with a large influx or bolus of patients. And I will say part of it's serendipity, and the other part of it is the nature of our healthcare system. One of the best things that we did that I would hope everybody else learns from is there was an immediate acceptance of the severity of this outbreak. There wasn't toe dragging or, oh, that's a blip, or that's not really going to be significant for us. I mean, I got a phone call at about 9:30 in the morning. I remember this so well because I was caddying for my son in one of his golf tournaments. And I literally pulled him off the course, and our whole executive team was in our conference center, which had been transformed into an incident command center within an hour of the outbreak, so to speak. So that immediate acceptance of the severity of this outbreak was one of the defining moments for not only EvergreenHealth in Kirkland, Washington, but the greater Seattle area and the greater Pacific Northwest, because all of the other hospital systems started to look towards us, not because we were better, but because, frankly, we were first. So that immediate acceptance was one of the, upon reflecting back on this, one of the pivotal moments in allowing us to manage this outbreak as best as I think that we have. We were very comfortable knowing that we've never seen COVID-19 before, but we were very well trained and prepared for a viral outbreak. Our hospital system looked at Ebola many years ago. We looked at SARS and MERS, and we developed an infrastructure so that we could revert back to that infrastructure if and when something like this happened. And so we were able to fall back on our training, so to speak, even though we didn't know anything about COVID in the way that that particular virus acted. We did have an infrastructure in place that we could rely on. And we became very comfortable understanding, as leaders and decision makers who are used to having things and data packaged nicely and in boxes, we became very comfortable knowing there wasn't such a thing as an ideal state. The data that we are being given, the data that we're learning and understanding is hyper-dynamic, and we became very comfortable even early on in the crisis knowing that the data we're looking at and making critical decisions based on was going to be different in 2 to 3 days. And so not having that paralyze us, not having, wanting to be perfect, so to speak, but saying, okay, this is the data we have. We're going to analyze this from multiple perspectives and make a decision. And by the way, everybody who we tell about that decision, we're subsequently going to tell them in 2 to 3 days, we're probably going to tell you something different. And we communicated that across the organization and across the region. And that method allowed us to really succeed as best as we have so far, if you can say that.
It's fantastic commentary, Mark, with respect to the experience there. And Dan, maybe shifting to you. I mean, you've got decades of experience in a healthcare leadership role, and based on your board appointments and other advisory responsibilities today, you have a broad view of the market and how markets like Seattle and beyond Seattle are dealing with this crisis. Offer some perspective based on your experience as to how other health systems may be approaching this and the critical decisions they're making, recognizing that across the U.S., everybody's on a different sort of part of the path as it relates to the curve related to COVID-19.
Sure, I'll be happy to, Matt. First, let me just congratulate Mark and his leadership team up there in Seattle for the great job they did at the early onset of this. It's a great example of how administrative teams and physicians need to be working together. Now, at Memorial Hermann, we've had great experience with natural disasters, where from Hurricane Harvey on down to Hurricane Ike to Tropical Storm Allison, and other events like Mark mentioned, Ebola, SARS, etc. The interesting thing about the learnings from all those is we knew they were going to be temporary and not a long duration, and we had a little bit more information. Today we're making a lot of decisions in vacuums. There's not a lot of great, reliable data out there that's real time. And so what I'm seeing, whether it's on the hospital health system side or if I'm on the Vizient side, the country's largest group purchasing organizations for hospitals and health systems, more than 4,000 hospitals purchase or supplies to them. We're seeing great variability in how hospitals are responding and their corresponding communities. Now, some of that variability is due to how variable the coronavirus is spreading from community to community, state to state. So there's a lot of ups and downs depending where you're at. And those communities could either be under tremendous stress like New Orleans and New York, or they could be under minimal stress. Houston, Texas, albeit there are 8,000 plus cases today in Houston, it's on a population of 7+ million, it's quite small, and the hospitals have excess capacity, excess ventilators, etc. So what are the big issues out there? First and foremost, for any hospital or health system, there are two overriding factors that got to be in place to effectively manage a crisis like this. One, you got to make sure all your frontline healthcare workers have an adequate supply of personal protective equipment. That's been a real challenge during this crisis. Some areas have plenty, others are in severe shortage. And there's really no way today to share that. And so what I'm trying to do is implore healthcare leadership to put down their competitive juices and start collaborating within communities or within regions and start sharing supplies where they have it. And it's going to be a challenge for months now to catch up on the PPE issue, because at no time in history have we had a worldwide epidemic like this all break at relative the same time. So the demand for these supplies are phenomenal. The second issue you really got to have in place to appropriately manage this is real-time testing. And that's been a real challenge for this country and individual states and communities. Without real-time testing, it's hard to determine where the hot spots are, who has it, and who they've been in contact with. So it's very difficult to tap down the spread of the infection. And so until we can get real-time testing, it's going to be very difficult to bring this under control. With that said, we're making progress. The last thing we would need is some good, proven therapeutics on how to deal with coronavirus 19. There are a lot of trials out there right now on experimental drugs. Hopefully one or more will prove to be effective. We're learning every day what works and what's not working. We're learning about the disease itself in terms of how it when you really start cycling down in the ICU, it's really a multi-organ failure that's causing a lot of the problems, not just the lungs and the pulmonary system. So, we're going to continue to learn, and then we got to exchange that data more quickly. And that's been a challenge also, is information and data exchange. So with that in mind, what are the lessons that we can learn? One of the things that I'm working very hard with a group of other national leaders is this country's one-size-fits-all approach is not the appropriate way to handle a pandemic like this. And so in most communities and states, in order to free up beds and free up protective personal equipment, they have shut down all elective, non-essential procedures, surgeries, and other healthcare services. What that has done is it's created a lot of unintended consequences. Death. We're hearing from doctors who are in the cardiology side who have had patients who needed valve replacements, who couldn't get the surgery done. They've thrown a clot and died. We've heard EP doctors who need to do electrophysiology procedures, and their patients are dying. So what patients can't get access to care, and I could go on and on. And what we need to be doing in communities is taking one or more hospitals that can do all the services, hold them offline, do not treat COVID patients in those hospitals, triage patients in a tent outside of the hospital, and if they show signs or tests for COVID-19, send them to the other hospitals in the community that have been designated to COVID hospitals. That allows one or more hospitals in a medium-sized or large community to stay open to do all the other types of healthcare needs that the community will continue to have. But when we shut down everything, we have ignored all the other healthcare issues out there, and we have to learn from that as a country. Now, smaller communities that are one hospital communities, what I just outlined is very problematic and can't be done. But most of the bigger cities, we should have a more collaborative approach and a more sharing approach on how we keep all healthcare services open, not just for COVID-19 patients. So with that, let me turn it back to you.
Mark, we just heard from Dan, and he touched on a couple things that I think are incredibly important and that you likely have great perspective on. One was a variability in response by regions or by systems. A similar point to what you shared is a lack of data to support decision making, and there's a real-time evolution of data that then better informs things in the future. And so ultimately, there's learnings as the country and really the world is going through this crisis. Given your experience in Seattle and being on the front end of many of these challenges, what are the things that you and your leadership team are sharing with other markets? What are critical learnings? And I guess we could probably break that into two pieces: the critical learnings for those who are sort of in the midst of the crisis and this broad community spread that's challenging health systems, and equally, or maybe even more importantly, communities where they've not yet seen that spread, but could in the future. I know there's been a lot that you and your teams have learned and are sharing.
Certainly. Well, I guess first I would say, Dan, we're bringing back retired physicians to the front lines, and I think there could be a role to bring back retired executives who think the way that you think. So you might want to consider re-entering the workforce if you're going to express such wise opinions. We have clearly gone down the road that he alluded to, and in some of the ways that he alluded to. One of the things that makes me most proud to be a physician is the concept of IP, which is very prevalent in our business community, and I want to endorse, obviously, it has to be to keep individual companies going. But our IP here at EvergreenHealth, as regards to COVID-19, the region of the Seattle region or Pacific Northwest, the IP or the expertise or the learnings or anything that we've picked up in how to care for patients, how to conserve PPE, how to appropriately hold back on elective surgeries while still providing urgent and emergent care to other people that need normal health care. We are sharing that and have been sharing that from day one with everybody. We are posting all of our work product, our meeting minutes, our processes on shared message boards. Every society in medicine has a message board where people can post and take things. And I know that our PowerPoint presentations have been spread across the United States, if not other places in the world, and we do that openly and willingly. So that's I think, a very great thing. Horrible things can bring out the best in people, and certainly within medicine, the data sharing that's going on has just been phenomenal. So our conservation approaches, I think, have been widely shared. Our forward thinking, so Dan already kind of alluded to this, and so did you, Matt. We are spending majority of our time focused on fighting this virus, and that has to be our primary focus, no question. We have to take care of the patients. We have to take care of our staff and our physicians. But if we forget to think forward to the future, if we don't withhold a small amount of our brains and a small amount of our capital resource to focus on our future, then hospital systems like mine, and I'm a very advanced community hospital with tertiary and quaternary care capability in a very sophisticated part of the United States. If my hospital caves under the financial pressure of COVID-19, then there are many other hospitals just like mine that will also do so. And so if we aren't thinking forward to, quote, keep the lights on, then we're not doing any good for our community. So that is one of the primary things that I think we can pass along. Yes, you have to flatten your curve. You have to care for your staff and your physicians, and you have to do the best job you possibly can to fight this virus. But as soon as you are able to divert some of your time and energy away from that without compromising that effort, you need to start focusing on the future. Dan talked about ordering supplies. He talked about PPE. All of those things are going to be potentially rate-limiting steps for hospital systems, and the trickle down to that goes all the way down to companies like NuVasive. How do we turn the lights back on? How do we restart the economy on a macro scale? Or how do we allow our healthcare systems to do what they do best, which is to take care of the communities that they exist in?
You know, Matt, this is Dan again. I want to follow up on what Mark was saying. I agree with everything he said. It's vitally important that we move as quickly as possible to the next phase. And a one-size-fits-all is not the right approach. It was in this early phase. We had to listen to the epidemiologists and other experts on how to contain this to the best of our abilities. And we just shut down everything. But what we're learning is all the unintended consequences, unexpected deaths beyond COVID. You know, I know communities, I've been gathering the data. Columbus, Ohio had an increase of 8 suicide deaths, mainly due to people losing their jobs and being confined inside. There's deaths spiking in substance abuse and all kinds of other medical areas because they can't get access. We got all kinds of domestic and child abuse problems going on. Substance abuse issues are rising. The economy, people, businesses, and the nation is hurting. We got to get back. The question is how do we do that in a smart way based on data and what we know? And what we know is that we can go community by community based on where that community is in its outbreak. And if that community has had a sustained reduction in coronavirus cases for at least 14 straight days, then you're probably safe moving to phase 2. And phase 2 has got to be well planned out. And in no circumstance should any community, state, or this country move to phase 2 without making sure that their PPE supply is adequate, their other supplies are adequate, that they're capable of testing more quickly and have the availability of the test, and also tracking positive tests and who they've been in contact with. If you can't do those things, then you're risking a reoccurrence at an even greater level. So as a country, we're not there yet. We don't have the testing capabilities at this point. So even though you're going to see some communities ease out of this and get well past their peak, it's going to be tough to open those communities up until those two things are addressed: PPE supply levels and quick testing.
So Dan, I think you bring up a great point around how we transition to a phase 2, and as you just outlined, we're not there yet. While there may be some communities that are approaching that, we're not there from a system perspective, ensuring that we have the resources to do that effectively. Certainly, we see the federal government stepping up to intervene in a number of areas, including ensuring an adequate supply of PPE and other critical devices. We also see the federal government stepping in and providing liquidity to the market and to healthcare in general. Can you touch on, from your perspective, a couple of the key federal initiatives that you think are most important in allowing the health systems to sustain this period of the crisis and ultimately bridge into phase 2?
Well, you know, it's pretty straightforward, and I touched on a few. Again, we as a country need to ensure our frontline healthcare workers have adequate protection, and we need all kinds of personal protective equipment, and we need it in adequate supply. That will continue to be a challenge. We're making progress on it, but we're nowhere close to resolving that problem. But that has to be done. There are other supply issues. You've heard of ventilators and other things. We can solve that, but, ventilators are not the only thing. What people don't understand is there's a real limit on true ICU beds. Can you use other beds in the hospital? Yeah, but you don't have all the different types of wall mounts and other things you need in an ICU to take care of an ICU patient, nor have you trained nurses to take care of these patients. Sure, good hospitals are taking nurses from the areas that have been closed down and are trying to retrain them as ventilator nurses or ICU nurses, but it's not the same as a skilled, experienced ICU nurse. The other things we have to work on is, again, quick testing. The biggest problem is a patient shows up with symptoms, feels they've been exposed, and have coronavirus, but a lot of times it takes anywhere from 3 to 12 days to get results back. By then it's too late, and you lost all ability to monitor the people they came in close contact with over the last number of days. So testing is critical in any type of epidemic that's going on out there. You also got to be able to actively monitor confirmed cases and their contacts and get that out to everybody. As a country, we haven't even come close to that. Other countries that have done a better job of containing it, there are different types of governments, obviously, and cultural norms, but they have done a much better job of active monitoring of their populations. One of the things we haven't talked about, if we're going to move to the next step, we got to come up with a better way to protect the vulnerable populations that coronavirus causes death in. We know what those are more and more. Clearly it's the elderly, and it increases with each decade of life. And clearly there's a lot of comorbid conditions that it impacts. So how do we protect those vulnerable populations, whether they live at home or they live in a nursing home or some other type of senior living facility? We have to do a better job if we're going to open up our economy, and we can. We need to also, the government needs to spend much more money and give more freedoms to accelerate the development of therapeutics that work against this disease. We've got some trials out there. It'd be interesting to see how they work out over the next 30, 60 days. But we need to accelerate therapeutics that truly work. And then last two things I would say is we need to increase the tests for antibodies in people that have been known to recover from COVID-19 and be able to identify them as people that are immune. The question is, how long will they be immune? Because we just don't know. Is it a short period of immunity, or is it going to be a lifetime? That will be determined. But we need to know who those people are and how many they're out there, because there's a lot of people that have had the disease, don't even know that they had it, and they have these antibodies that would be appropriate to identify. Lastly, we got to spend a lot of federal resources and business resources to develop a vaccine that works. This is pivotal to the success, because more and more epidemiologists that I'm talking to are starting to talk about a second wave and maybe even a third wave, the second wave beginning in the fall. And if that's going to be the case, the quicker we get a vaccine, the less impact it's going to have that the disease and the epidemic will have on our economies and on the health of our people. So those are the things I think are critically important for government to focus on, whether it be the federal, the state, or local. And those ought to be done in conjunction with the healthcare providers and the medical technology and medical device companies.
Thank you both. In part 2 of our discussion, we will pick up where we left off and hear perspectives on what recovery looks like in both the near and long term.